Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with SWORBHP. Welcome to yet another webinar presentation. Today we're talking about DNRs and going through some of the issues that some paramedics face when presented with a DNR. Today presenting we have Justin Lammers, an ACP with Essex Windsor EMS. We have Dr. Paul Bradford, Local Medical Director, and we have Pete Morassutti, who's one of our regional paramedic educators. So if this is your first time watching one of our webinars, you'll see a control panel and a PowerPoint presentation. In the control panel, you have the option to ask questions sort of in the background by typing them to me, and I'll manage those again in the background. So I will communicate with you via text that way. At the end of the presentation, if you happen to have a microphone, you do have the option to raise your hand by clicking on the little hand icon in your control panel. So at the end of the presentation, if we do have time, I can unmute you and then you can ask your question live. So without further ado, I will pass the presentation over to Justin, Paul, and Pete, so you guys can take it away.
Okay, hi everybody. My name is Justin Lammers and I'm an advanced care paramedic for Essex Windsor. I put this PowerPoint together. Basically, I found myself in the past running into some situations that were kind of gray. I had a hard time finding an actual clear-cut answer as to what to do. And following through with the Ask Mac website, I saw that there was a lot of people out there who had questions, and getting a clear answer was tough. So I guess we'll start with the presentation. I change slide. Hold on a second, guys. I'm having a difficult time here. I won't change the slide for me. And voila! Okay, so some of the learning objectives. Today what we're going to do is we're going to explain what a DNR is, its rationale, and how it relates to our practice. We're going to discuss the meaning and implications of the confirmation form, treatments and procedures, and cannot be performed on a patient who has a valid DNR. And we're going to describe how a valid DNR might alter our practice in a variety of patient care scenarios. What is a DNR will be discussed, DNR validity, substitute decision makers and who they are, revoking a DNR and who can do that, and what if DNR scenarios, and hopefully we'll get some good discussion out of that. DNR, as we all know, DNR abbreviations do not resuscitate. This is a legal order written on the form. It's respecting the patient's wishes to not have CPR or ACLS interventions in the event they suffer cardiac respiratory arrest. With that being said, this is the definition, but this brings about great debate regarding treatment up to and including a cardiac arrest. As stated on SWORBHP's website, March 1st, 2012, think of the DNR confirmation form as a list of specific instructions how they wish to be treated when they become extremely unwell or have arrested and they are unable to communicate for themselves. The key with that is to remember that it's up to and including, and I think it's the up to part that is creating the confusion. Right off the DNR form, means a paramedic, according to scope of practice, will not initiate basic or advanced CPR, such as, and we have listed chest compressions, OPA, MPA insertion, defibrillation, ETT, artificial ventilation, and transcutaneous pacing, and drugs such as, but not limited to, vasopressors, opioid antagonists, and antiarrhythmic agents. If your patient has a DNR confirmation form, none of the treatments listed prior should be initiated. The confirmation form does not state that arrest must occur to avoid these procedures, so this is going back to our pre-arrest state. Another example stated on Ask Mac, if a patient has a signed valid DNR confirmation form and has decreased LOC with oxygen sats of 60, despite 100% FiO2, but they have a perfusing rhythm and blood pressure, this patient should not be intubated. What is a DNR? For the purpose of providing comfort palliative care, the paramedic, according to the scope of practice, will provide interventions or therapies considered necessary to provide comfort or alleviate pain. These include, but are not limited to, the provision of oropharyngeal suctioning, oxygen, nitroglycerin, salbutamol, glucagon, so pretty much our symptom relief protocol, ASA, epidural anaphylaxis, benzodiazepines, morphine, or other opioid analgesics. So this is going to be...
Is like an analgesic, like an analgesic?
Yes.
Okay.
So these are going to be basically our comfort measures for the person who, let's say, is pre-code, just to make them more comfortable, basically in the end. Previous list of items in Part 2 of the confirmation are used for comfort or ease pain in the patient, as your standard protocols would normally be used. This shows that despite the patient having a valid DNR, there are treatments still available for this patient.
Do we know what kind of treatments are available?
This is going to be anything like your symptom relief, so this is going to be oxygen.
Did you see the last list? Like the whole thing was like laid out there. They had all pretty much everything you carry in your bag, right? All right, you could use it.
So if somebody say they have chest pain and they have a DNR, I mean, we're able to go ahead and go through that protocol for our nitroglycerin and ASA. Somebody who's hypoglycemic, we still can give our glucagon, things like that. A big question that was brought up that some people are asking is CPAP. Is CPAP something that is going over and above in the pre-code patient? And maybe we can get some advice here from our local medical director.
Yes. Yes, it's going above, and it's positive pressure ventilation. So that's considered, resuscitation, if you will. So you're not allowed to really bag them or, do anything where you're actually actively bagging or actively providing pressure. So CPAP would be included under that.
So actually, while we're on this topic, a question has come through via the chat box. So the question is, if we have a patient who's presenting with signs and symptoms of a stroke, but the patient does have a valid DNR, do we still run them to the stroke facility under stroke bypass? What do you think?
If I'm not mistaken, I thought that was a contraindication of the stroke card, but I may be wrong.
Yeah, I mean, I think the idea is like if they're arresting, that's when the DNR applies. Otherwise, they could be actively engaged in a community or doing a lot of purposeful television watching, and they may be having a fairly decent quality of life other than that, and they just decide that they don't want to be, put on a ventilator and managed with resuscitation or whatever. And so in that regard, yeah, I think, I think it's, especially if you can get them to the stroke center and fix the stroke, then it's almost palliative at that point too. They can have a better quality of life if you think of it in that way. If you think of it in that regard.
Great, thanks, Paul.
So the DNR confirmation form came about February 1st, 2008. The Ministry of Health put this out, and it was a standardized form for all paramedics and firefighters to follow. It's basically to ease confusion on the scene when you're presented with this. This form is signed by a physician, an RN, a nurse extended care, or an RPN, and this confirms that the existing care plan does not include CPR. Now, when you get on calls in, not so much a hospital, but when we go to these nursing homes and we get a DNR form that's not the Ministry of Health confirmation form, and it's level 1, level 2, level 3, they have all these different check boxes for DNRs. This is what the confirmation form is getting away from, okay? Within the hospitals, there's different levels of care that may be chosen. For us, it was decided that to alleviate confusion on scene, there'd be one standardized option. And if the patient is transported at the emergency room, the physician could then sit down with the family and they could discuss alternative treatment plans. Basically, the confirmation form for us was, are we either going to resuscitate this patient or not?
And I think the other point to bring up there is part of the problem with that is the DNR forms in the nursing homes where they pick different levels of care for people that are staying in the nursing home who perhaps I want to just be kept comfortable and I don't want any intervention whatsoever, or I don't want CPR or defibrillation or to be put on a ventilator, but I would like antibiotics if I was to get a urine infection, that type of thing. That system is in many ways is a different nomenclature than what's used in the emergency department. So you might be like a level 4 DNR at a nursing home, but that might be a level 1 DNR, at the hospital, right? So it would be impossible to standardize that across the whole province, and that's why, it's not that paramedics can't understand this. I think it's meant to be, we need to know right now, we're here right now, what do we do, yes or no? Because I need to know what my next step is right now. And I think that was where that really came from.
So here's just a copy of the do not resuscitation confirmation form. We've all seen this in the field, but this is just put up there so we know we're all talking about the same thing. You can see the serial number at the top there. That's the big thing we're looking for, is that it is valid with the serial number, and it is filled out accordingly with the physician, nurse extended care, or RPN having signed it. So here's a little scenario where a patient is being maintained by equipment, leave it in place, i.e. intubation. So if they're intubated, they remain intubated. You don't extubate them. If the patient does suffer cardiac or respiratory arrest, no additional interventions are given. The big question some people had was, if they do wind up going BSA, do we shut the vent off?
Well, I think, if you look at the escalating event of something happening, you could see that someone might be in a chronic care facility and be intubated by the team until it was determined that they're DNR and have to be transported to another hospital. We have a sort of nursing home type facility that does that in Windsor, where paramedics will respond in 911 to anyone who codes, as there's not resources 24/7 to do that. So you can see how that may be an issue. One of the issues with taking out the endotracheal tube is, if it's someone's palliative and the family's there, that you may have someone who's breathing, but you may have this sort of horrible gasping, breathing, choking business that happens, which for some people they find very disturbing. So it's probably better to leave that if it's already in place. And if you're going to remove it, that might be a discussion you want to have with the family to explain what's going to happen so that they understand that's going to happen. The issue with shutting up the vent, usually that's in the hospital when it happens, the staff asks for an order to go ahead and shut the vent off. You can call a BHP for an order to shut the vent off, but if the patient's intubated, or if it's a prolonged transfer and you can't get contact, I think it'd be fine to go ahead and turn that off at that point.
Just touching on that, what Dr. Bradford was saying, many times in the Ministry of Health DNR training package, it does say to always err on the side of life. So if you ever catch yourself in a situation where you're not sure, erring on the side of the life you'll never be faulted for. And like he said, contacting the BHP, that's always our kind of ace in the pocket there. We can call and get some orders. The DNR validity form, like I said, there's a 7-digit serial number in the top right corner. This is what confirms the authenticity of the form. If there is no serial number there, the form is invalid and it's not acceptable. So at this point, if the patient did arrest, you would be working them. It is a durable document, meaning that it's used several times. You don't need the master copy. Photocopies are acceptable. Required information on the DNR validity form for it to be valid, again, is the 7-digit serial number. All the fields have to be filled out. A valid healthcare provider has to sign the form, and if at any time it's determined that the form is not valid, you just continue care and treatment.
Another question has come through, guys, actually, while we're talking about family members. So the question is, if you have a patient who is VSA with a valid DNR, and a family member is now saying that the patient has recently expressed a desire to void that DNR, sort of what do you do in that case?
We're going to touch on that in a couple of slides here, and that basically comes into substitute decision maker and revoking the DNR. So not to brush aside your question there, but we're going to get to that in a few slides.
Perfect, thanks.
So the validity form, again, checking the first box, this indicates a plan exists and that it does not include CPR. It indicates that this was the patient or substitute decision maker's wishes. By checking the second box, it indicates that in the physician's opinion, CPR will almost certainly not benefit this patient, and this will have been discussed with the patient or the substitute decision maker at that time. So who is a substitute decision maker? This person is assigned by the patient to make the health-related decisions if they cannot make them, the patient cannot make them for themselves, or if they are incapable. The person is usually chosen prior to the patient experiencing illness or injury.
Now, is this the power of attorney or is this the power of personal care? Because now you have that both.
It's two separate things. There's a power of attorney and there's a substitute decision maker. So this is kind of its own entity. Say someone was involved in a car accident, put on life support, and a substitute decision maker was never assigned. There is guidance within the Healthcare Consent Act that will legally authorize a substitute decision maker. So this normally goes to next of kin, or if they had a power of attorney, or a close family member. If in a situation where there is no family, there actually are people out there that is what they do. They become a substitute decision maker for people who are unable to make healthcare decisions on their own.
Yeah, there's like the power of attorney for your money. Right? We should never sign that over, right? And then there's the power of attorney for care, which would be very highly ranked in the substitute decision maker listing.
So a power of attorney, this is determined when the patient is well, and a POA for personal care form must be complete. So there are steps in place to make sure that this is government regulated as to who these people are. The Ministry of Health states that paramedics are not expected to investigate the condition under which a DNR order is made, nor are they required to review or confirm the DNR order written in the patient's healthcare record. So it's not on you to investigate the DNR. If there's a valid DNR, it is what it is. You must make a reasonable attempt to confirm the patient who is named on the form is actually that patient. So it says here verbal confirmation from family or staff is acceptable, a wristband, anything like that to confirm that this is the patient. Revoking a DNR, so touching on the question that we had last, it can be revoked, and this is at any time the patient themselves or the substitute decision maker expresses this. So this can be literally as the patient's making the last breath that they want to be resuscitated, then the DNR is no longer valid and you do resuscitate them. Again, touching back from the Minister of Health on err on the side of life. If the physician or RN has determined that the treatment plan has changed and now includes CPR, this is another reason that it would be revoked. If the patient or substitute decision maker withdraws consent and expresses wish to have CPR, and if a DNR cannot be produced or is taking a while to produce. So if you can't actively get your hands on that DNR, then you start CPR until which time you can, or phone the BHP and explain your story if someone has a credible story stating that this patient's expressed their wish not to be resuscitated.
Actually, while we're on the topic of substitute decision makers, do they need to have some sort of paper to show the medics? Do they need proof?
As far as I've read, you don't need to investigate that. If somebody identifies themselves as a substitute decision maker, then that's who they are. But there's nothing in the Ministry of Health stating that we have to see some ID or something like that.
It's something that they ask for at the hospital occasionally, but often very rare that's actually you even ask for the document to be produced there.
Yeah, and now it also says in the Ministry of Health that even a close family member, if they start saying, nope, this person last night was saying that they want to be resuscitated, again, we're erring on the side of life that this person wanted to be resuscitated.
So if we have two or more in the room, say one saying yes and one saying no,
yeah, you know what?
who do we go to?
Pick the bigger person.
Yeah, the biggest guy.
No,
Who's smaller than me?
I think what you do there is you'd resuscitate and you'd work that out after you got to the hospital.
Right, and that's always an option, right? We can always resuscitate and leave the scene, and then in a calmer environment, we can kind of get the details worked out. So another question here from the Ask Mac, and it's a big question. Should you honor a patient's DNR if they are choking? And the response to that was the duty of all paramedics and frontline providers is to assist patients. A valid DNR does not preclude a patient from attempting to assist a patient, does not preclude a paramedic from attempting to assist a patient who's choking. However, once a patient has suffered a cardiac arrest for whatever the reason and this patient has a valid DNR is to be followed as described. So if they are actively choking, yes, we're doing the Heimlich, yes, we're doing our chest compressions to get the obstruction removed. If they do arrest during this time, then the DNR is now considered valid and resuscitation efforts would cease at this time.
I think that, it sort of makes sense from a palliative part of it. Like, it'd be horrible to choke to death, and I think you're trying to relieve suffering, and some of the interventions we do for those people are aggressive in some ways, right? So I can certainly see the confusion, but I think if people keep in mind the idea is that when you're signing this, you don't want to be put on a ventilator and have CPR and all those things, but I don't think you envision it when you're signing it that they're going to stand and watch you choke to death. So I think if you actually had a case, it'd probably be pretty obvious.
Another question from Ask Mac. Is a valid DNR a good reason to not transport critically ill patients at a high CTAS level? The response was the DNR should in no way influence the CTAS scoring. It is not listed as a modifier in the latest teaching package from Ministry of Health. I don't know what your feeling is on that. If we have somebody, who's a CTAS 2 with the DNR, are we going to be, tearing through the city lights and sirens for somebody who we know that the critical interventions are not going to be done at the hospital?
Well, I think if you have someone who's fallen and broken their hip, they could be in a lot of agony and a lot of pain, and you might want to do that for them to get some pain and comfort. So, I think you're going to advocate for your patient and use your own judgment in that regard. And sometimes keeping people comfortable, that's a really important role for us. And I think you would never want the public to feel that, well, as soon as I sign this DNR, I'm now going to get delayed care or worse care or not access to care anymore, right? Really what you're saying is, I'm signing this form saying I really don't want to be put on life support, right? But, otherwise I'd like to be well cared for. And so I think that is, it does make sense. I mean, the survival from cardiac arrest is low, and you can certainly end up worse off in many cases as we get older. So I think that's an important distinction that people have confidence that, when I sign this, I'm still going to have all of the other care except for that one part when I'm about to die.
So the DNR confirmation form states the paramedic will not initiate basic or advanced CPR such as transcutaneous pacing. From what I understand, and again, this is a question off the ASMAC website. From what I understand, until that person suffers cardiac respiratory arrest, they are fair game for treatment. So if a patient is in a third-degree block at 20 beats per minute and they have a valid DNR form, are we pacing this patient?
Well, I think that's a really challenging one, right? That's probably the one I have the most problems with personally, because you have a patient who perhaps has a low heart rate. Often these people are in nursing homes and they've had falls, and maybe people aren't putting it together initially. That's because they're in a blocked rhythm, and then they get sick with whatever, and then so they keep giving them all their blood pressure pills. So you're not feeling well, but in the nursing home they keep jamming the pills in each day. When you got to have them twice a day until you kind of fall to one side and they can't jam the pills anymore, and then they call the paramedics, right? And then you bring them in, and then lo and behold, you get there and the heart rate's really low. And this patient, if you hold the pills for a few days and hydrate them again, they probably would be okay. And a pacemaker is not really a giant intervention, right? You put it under the skin, you can get when you're 95. I mean, and they could, continue their purposeful television watching or whatever they're doing, at that stage, and have a good quality of life. So that's a difficult one, but it's fairly clear in the DNR process that transcutaneous pacing is an intervention, is a life-saving cardiopulmonary resuscitation intervention. So it's very clear on that not to do it. That being said, I think if you have a case where it's 20 beats per minute and unconscious and so forth, that's pretty clear. I think where you're going to be challenged more is when the patient's got a heart rate of around 30 or 40 and they're sort of conscious and in out of consciousness, and that's difficult because you could offer some intervention there on palliative, because if you can, you may not die, right? You may just have a really low heart rate and be laying there and see if you do anything, you have a really bad quality of life. So it's very rare for people to kind of just have that, one presentation of low heart rate. We see a lot more people in the gray zone, right? And in that regard, when I personally had cases like that, I discuss it with the family, discuss it with the patient, and they can decide what they want to do, how interventional they want to be. And I had one recently that decided to have a pacemaker, and that they wanted it, and we went ahead and did that. And then they went home, and they were still DNR, if anything happens to them. So, but for now, for paramedic purposes, you shouldn't be pacing anybody that has a valid DNR.
So would you say this is one of those situations where we're better off bringing them to the hospital and letting you guys discuss this treatment option with the family?
Yeah.
And if they were to, go down route, then that would be when the DNR would be enacted.
Exactly.
Now, what if you go the other way? What if you go to cardioversion? You guys in a super fast rate. He's in and out of consciousness. Should we hit him?
Yeah, I think if
cardioversion or adenosine or anything like that.
I think the medicines are I don't think they were on that list, right? The adenosine, and I think if he's suffering from it, that could be a phone call to the physician to see, right? If he's suffering from it. I think I would treat that.
Treat the cardioversion.
But I think under the DNR thing, if it's on that list, and I believe that cardioversion was on the list, and I think any arrhythmias were on the list, then you're going to have to phone, to try and do that. So that's a great question.
You're welcome. So here's the answer here, as stated on the ASMAC website, that if a valid DNR confirmation form is available, none of these advanced cardiopulmonary resuscitation procedures should be initiated, period. The SWORBHP medical directives would suggest that this is independent of whether the patient is completely arrested or not. So here, if there is an on-scene delay in obtaining the DNR validity form, what do we do? And the answer from ASMAC was that if there is a delay in obtaining the fully completed DNR confirmation form in a patient who suffered a cardiac arrest, CPR is to be initiated until such time as the form is produced. Alternatively, paramedics should follow local policies where they exist for termination and resuscitation. Patching with BHP is always an option. Myself personally had a scenario like this where the nursing home stated they knew they had a DNR, but they weren't unable to locate it. and they were contacting family. We started our protocol. We ran our code. By the time we were ready to transport, the form was not available. We did transport. Halfway through transport, dispatch contacted us that the family had been able to get a hold of the family and that there was a DNR and family did not want resuscitation. At this time, I phoned the BHP. I got an order to terminate resuscitation, and we did so and transported to the hospital. So it's, again, a great scenario, but it's just showing that you can always fall back on the BHP for direction. So that's pretty much it for the DNR package that we put together. At this time, if anybody has any questions or scenarios they'd like to run through, we'd be happy to go through those with you.
So at this point, we've been taking questions sort of throughout the presentation via the question box, the chat box. So if anyone wants to actually speak live and they have a microphone on their computer, you're more than welcome to do that. So if you want to do that, click on the little hand in your control panel, and that shows me that you've put your hand up, and I can see that one person has. So I'm going to actually unmute you, and when I say go, you should be able to speak, and we should be able to hear your question. So Nicole, go ahead and ask your question.
Okay, I don't know if you guys can hear me.
Yeah, you're kind of quiet, but we can hear you.
Okay, it actually is similar to the scenario Justin just said in the back of the truck, the pronouncement there that took place in the back of the truck. We did a VSA at a nursing home. The patient was on a day pass from the hospital with his daughter, going around looking at all of the nursing homes that he wanted to go to, and he collapsed there. Now the daughter was there and said the DNR was at the hospital. Would it be the same scenario that we would get in touch with the hospital and find out if they could get the DNR, and then we could do termination of resuscitation?
I'll let Dr. Bradford answer that. In my opinion, that is somewhat the same scenario. I don't think I personally would be investigating if the DNR was valid. If that was the family member there, like you're saying, it's the daughter, I would phone the BHP and advise the situation. And I personally don't see any reason why you wouldn't get the order to pronounce them.
Yeah, Nicole, I think I would call as well. I mean, you can start things and then call just to cover yourself. There may be other family members, or the information might not be accurate. If you want to cover yourself, but I think 100% of the time you're going to get cease resuscitative efforts from the BHP on that.
Okay, very good. Thank you.
Thanks, Nicole. If anyone else would like to do that, absolutely raise your hand and I can unmute you. In the meantime, we've had a couple typed in questions. And again, I think this sort of refers back to whether we can call the base hospital physician for advice. So this one here is, if the patient has CCAC DNR directive, but no DNR confirmation form, sort of what should we do in that case? Can we call the BHP for advice?
I would say, yeah, and I've certainly had that where they're just about to send out the death kit to someone dying at home of terminal cancer, and they just don't have the paperwork, and it's supposed to be, it's like on a Friday that it's done, and the person's not going to be there till the Monday that does the forms, and we've certainly had those situations. And every case, paramedics have shown great professionalism, common sense, and made these calls, and we've been able to respect the family's wishes.
Thanks, Paul. And sort of with that, I think we should maybe clarify the point that if the patient does have a valid DNR, you do not need to contact the BHP. So keep in mind that contacting the base hospital physician is sort of for advice in the cases where the family is asking that no resuscitative efforts be put forth on the patient, but that they do not have a valid DNR confirmation form. So again, I just want to reiterate that if they do have a valid DNR confirmation form, you do not need to patch to the BHP.
And that's only the form, correct? The Ministry of Health form, not a nursing home form.
Right. It's called DNR validity form.
All right.
Okay, I think that sort of answers a couple of the questions that we've had typed in. Does anyone else, would anyone else like to raise their hand and ask a question live? We'll leave it open for a few more minutes.
Now, if you arrive at the scene and fire has already started the CPR, right?
Never happens.
Never happens. We know that. It never, ever happens. Say that it does, and the family presents you with the DNR. Do we have to make that phone call to you?
No, I think if you've got if the paramedic's satisfied, the paramedic is is really the subject matter expert on that scene for health health issues. And if the paramedic's happy that that's a valid DNR, that's good. And just document that, you're good to go.
And keep in mind, too, if you've started resuscitative efforts on a patient, which means you then did not have a valid DNR confirmation form in your hands at the time, and then family or staff or whoever presents you with that form, let's say after your first rhythm interpretation or your first analysis, at that point you can honor the DNR confirmation form. So at whatever point you receive that paperwork, you can cease resuscitative efforts, but make sure that you do start those efforts if you don't have that confirmation form. Okay, we're just having a look at a couple questions here.
I think John Booth's question there, why nursing homes don't have a photocopy of the DNR at patient's bedside. You know, that is something that we run into a lot where we get to the nursing home, we're called out for a VSA, and we get there and, you know, a DNR, yeah, let me go check, you know, and it is a pretty crucial piece of paperwork that we need. So I've found in the past that sometimes when we get the call to a nursing home, I will ask dispatch to see if they can locate a DNR at the facility so that when we do get there, when we roll through the door, we do have the proper forms and we don't have to start resuscitating if that's the patient's wishes.
We can have like DNR only nursing homes. Like when you go in, you got to agree to this when you go in, part of the deal.
Well, and that's another thing. Some of the nursing homes in Windsor or assisted living homes, some of them, one of their protocols, I guess, is nobody has a DNR. I've been to a couple of them where I asked about a DNR and said, no, nobody here has a DNR. It's assisted living. So it's something to look for.
Definitely some of the questions that we need to ask on these types of calls. So it looks like we don't have any other questions, and nobody else has raised their hands. So a short and sweet webinar. We've only taken up 32 minutes of your time, but you will be granted the 1 CE point should you attend.
Awesome.
So a pretty good day. I'd like to thank everyone for attending. Keep an eye on your email from your services to hear about any future webinars. We're looking at EMS and midwifery in January, as well as an ECG series starting in January as well. So thank you once again, and have a great day, everyone.